This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. Hello, Thomas. I want to ask you a quick question. What's over 30%?
How about people not wearing masks?
Well, that's a pretty good answer, but we've had an increase in COVID-19 hospitalizations in North Texas to increase over 30% in the last 2 to 3 weeks. So you know what? You're right. Wear a mask.
Wow, so you're talking about literally thousands of new cases per month.
Yep, we've had new cases. We've got more people in the hospital. I know people are tired of hearing this, Thomas, but they got to wear a mask, physical distance, wash their hands, get a flu shot. And that's why we're going to have 2 guests today talking about COVID-19.
Well, and we've just seen it in the headlines, and I know, we don't cross that political line, and I have used your lines so many times in other places. We have Republicans in our hospitals and Democrats and independents and libertarians. It affects everybody, and everybody is susceptible to it. But we certainly saw something played out on the dramatic national stage that indicates we're not done with COVID-19 by any means.
I think if anything, and you're right, COVID-19 doesn't care what your political party is, but COVID-19 is spreading in the community. And I think what we saw on the national scene was COVID-19 is still here, and it is still spreading.
So we're going to have a guest start the show today who used to work for the CDC. His credentials are a mile long, and just know that he is so well-versed in this area. And over the course of the next 30 minutes, he is going to tell you 2 stories of tests that they've done that if you don't think that a mask won't help, you will be convinced if you will stay with us for the next 30 minutes.
And again, we're going to bring back Dr. Robert Haley. I think many of our listeners recognize Dr. Haley by now, but he's the chief of epidemiology at UT Southwestern Medical Center. And welcome back to the show, Dr. Haley.
Very happy to be back, Steve. A lot to talk about.
Well, let me ask you, just out of the, where did masking come from? Where did it originate?
Well, that's very interesting. There's not much evidence that it was used on any big scale until the 1918 influenza outbreak, the pandemic. The great pandemic that killed between 50 and 100 million people worldwide. And in that one, people learned pretty quickly that if they wore masks, it kept them safe. So, and then there were laws and ordinances, local ordinances and state laws that people had to wear masks. And back then they actually put you in jail if you didn't wear a mask. So it got pretty strong, adopted very strongly. And after the pandemic, then people realized how important it was. So they used, hospitals started adopting masks to prevent the spread of tuberculosis, which back then, was consumption, which killed young people. So it was really bad. And then that developed into a full-blown system of isolation precautions in the hospital to isolate people with contagious diseases. And wearing masks was the mainstay, the most important part of that for these airborne infections. And then it was widely practiced in Asia. Asian countries really adopted it because they have had more of these, the bad influenza. That's where influenza arises every year, usually from southern China. And so they have a longer history now since the great 1918 pandemic of wearing masks, and have taught us a lot more about it over the years.
So as we look at that, and I know you mentioned really in the United States and in many parts of the world, the great 1918 pandemic is when people really began to use masks. Is there any other nugget of information related to the first evidence, other than that maybe, that it actually worked and helped prevent the spread of any type of infectious disease within the United States?
Yes. First of all, let me mention that in Asia, they've been wearing masks for literally decades. And if anybody's ever traveled to China or Japan or any of the other Asian countries, you know that when you're walking down the street, you often see a person here or a person there wearing a mask, and you ask somebody, why are they wearing a mask? And they say, oh, well, we always wear a mask when we get a common cold. It's just courtesy so we don't infect everybody around us. So they've been doing it for decades. And then when SARS, you remember SARS? It was that first coronavirus that was really, really serious, killing lots of people. Well, it was a big deal in Asia. And so they put their masks on and pretty much eliminated it and kind of saved the world with masks. And then there was MERS, the Middle East Respiratory Syndrome, and masks were very helpful there. So by the time COVID came along, COVID-19 came along earlier this year, the first epidemic was in Wuhan, China. Everybody's heard that. Well, you know how long that lasted? The first big epidemic in China? They had it eradicated in a month. I mean, the thing went crazy. They identified the virus, but they all were used to wearing masks. So they had 98% compliance with masking in Wuhan, China, and the thing was gone in a month. And so that was the first real evidence that we in the West noticed, gee, they got rid of it, and look, we still haven't gotten rid of it, but they got rid of it in a month. It came back once or twice, got re-imported, and each time they snuffed it out by wearing masks. So I think that was the first real wake-up call. Now, and then very shortly it occurred in the United States. At that time, all the evidence was not in, and so the CDC and others recommended that we not wear masks because they wanted to preserve the N95 and high-efficiency masks for the hospital personnel who are treating these people and are at terrible risk, and they didn't want to use those out on the population because, as we've seen, we'd run out of them. And so they said we don't need to mask out in the population, but then very quickly, within a month, on April the 3rd, of this year, the CDC reversed position and said, wait a minute, you don't need an N95. A cotton mask will do because that's what they've been wearing in China and in Asia for a long time. So they started recommending that we all make our own cotton masks or whatever and just cover your face, and that will work. So from that, then, there was a long line of really great experiments that have proved beyond any doubt that if you wear a mask, it not only prevents you from spreading it to others, but if you're not infected, it protects you from getting the infection. So that has now been well proved.
Dr. Haley, quick question before we break. Is the virus less severe now than it was back in the spring?
Absolutely not. This is, a lot of viruses mutate and they either become more or less virulent. This one is a slow mutator, so it's not changed at all in terms of virulence or spreadability.
You're listening to Dr. Robert Haley on the Human Side of Healthcare. He is professor of internal medicine and the director of the Division of Epidemiology at University of Texas Southwestern Medical Center. He also spent 10 years at the CDC as an epidemic investigator. When we come back, he has 2 recent examples of tests that prove beyond the shadow of a doubt that masks not only work, but what kinds of masks work. Stay with us. We'll be right back.
This is the Human Side of Healthcare on 1080 KRLD and the radio.com app, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back to the Human Side of Healthcare. We're continuing our conversation with Dr. Robert Haley. He's with UT Southwestern Medical Center and also spent 10 years at the CDC as an epidemic investigator. And viral and pandemic investigations are right up his alley. Here's Steve.
When you go out on the street, for the people that are wearing masks, and we are so thankful they come in all forms, all shapes, sizes, colors, some really, almost like an accessory that people like to wear. But all kidding aside, what masks, in your opinion, are the best for our listeners to wear?
Well, that has been answered by some very good scientific experiments. Let me just quickly quote or summarize that there was an experiment done at Duke University. Actually, it was a very simple, cheap experiment. I wish I'd thought of it. But they built a kind of just a black box that sits on the table, and they put a slit in one side and would shine a green laser light through the box, and then had a camera in the back of the box shining in, and then a person in the front of the box with a big round hole where they could talk into the box. And when they would talk, the droplets would come out of their mouth, and the laser would light up the droplets, and the camera in the back would photograph that. You could actually see the droplets coming out with this laser. And so the person would sit in front of the box with or without a mask, and they would say, "Stay healthy, people." That was an objective phrase that they would repeat over and over, and with different masks on, and then they were able to quantify the number of droplets that were produced. And when a person had no mask on, you could just see the needle on the measurement screen going up and down as they say, "Stay healthy, people." And there were four or five big spikes of droplets spewing out. And then they put an N95 mask, the one they use in the ICU, the healthcare workers use, 100% blocked those drops. No drops came out. It was just dramatic. And then when they put just a regular surgical mask, like a surgeon uses in the operating room, almost the same thing. Almost complete blockage of those drops. And then they tried some pretty heavy cotton masks, and they were almost as good, like about 95% blocking. And then they put some T-shirt material, a couple of layers of T-shirt material, and they were pretty good, okay? But then they used one of these gator masks, that comes up from your neck, that's only one layer thick, and it was like no mask at all. The droplets just came right through because it's only one layer. If you had a 2-layer gator, it would probably work fine, but most of them are just one layer. And then some things like fleece that's, hardly not like a mask at all, and that's like not wearing a mask. And so anyway, so almost any cotton mask that as long as it's more than one layer thick, it's going to be very helpful in preventing you from spewing those droplets out. And that's now just absolutely proved how efficient it is in blocking the exposing of others through the mask.
So, Dr. Haley, what about people that say they don't know about masks? The virus will go right through it, especially if they're not an N95 mask or a surgical mask. What do you say about that?
Well, that reminds me of back in the early days of HIV and AIDS. You remember there was a group of people who wanted to quarantine all the people at risk for HIV, and they showed magnified pores of condoms and saying, "Oh, look, there are holes in these condoms, so they don't work." I think that's the same kind of disinformation that we saw back in the early AIDS, and probably from the same crowd. I don't know, but no, that's absolutely false. The size of the pores is kind of irrelevant, because first of all, and that's why you need more than one layer. See, if you have 2 layers, now wherever there's a little pore, there's another piece of material there to catch it. Second, you don't have a single virus being spewed out. What you have is droplets, and they're droplets of various sizes. And those droplets are caused by turbulence in your larynx and your vocal cords, making turbulence, and then back in your throat and in your mouth, and that's spewing out actual droplets. Well, a mask will catch those droplets, and that traps the virus there before it gets out. And so, see, you're not stopping individual virus particles, you're stopping droplets, which are larger than those pores, and besides, you've got 2 or 3 layers of material. And of course, regardless of the reason that this works, the bottom line is, from the experiment I just described, it works. Particles don't get out. And so it's just proved beyond a doubt. But in fact, let me mention one other experiment before we quit, because I think this one would answer that question even better. and it to me is the definitive study that I think about the most. And that is a group of really bright researchers used a study in guinea pigs. Guinea pigs are very much like humans, that they're very susceptible to COVID. And so they would put two cages right next to each other with a little very light breeze blowing from one cage to the next. And in the first cage, they put some guinea pigs that had COVID viruses put in their nose. And so they became infected and became very sick. And when the study was over, their lungs were examined, and they had severe lung pathology. The lungs were really kind of destroyed by the virus. And then they put a second cage, next to it with healthy guinea pigs to see if they would become infected by the air coming from that first cage to the second. And sure enough, those guinea pigs, the healthy guinea pigs, became infected. Almost all of them became very sick, and most of them died and became sick very rapidly, and then had severe lung pathology. Then they put basically a surgical mask material on the healthy guinea pig's cage. They set that up again and put like mask material on the cage of the healthy guinea pigs, was like mask, sort of simulating putting a mask on the healthy people. And sure enough, a few of the guinea pigs got sick from the sick ones, but it took much longer for them to get sick, so their immune system had time to kick in and protect them, and none of them died, and they had very mild illness and very mild pathology in their lungs. And then they did it a third time. This time they put the mask material on the cages of the sick animals, okay, and repeated the experiment. And now the healthy animals, only like a tiny number of them got sick, and they were just mildly sick. The illness again was delayed, and there was no lung pathology in those. So what this proves beyond a doubt is that a mask is very efficient in protecting those. If the sick person is masked, it's protective by two ways. One, it makes you get less virus. You're exposed to less virus. And because you got a lower number of viruses, your body is able to handle it. So it takes longer for those viruses to get through your lungs and make you sick. And so your immune system has time to respond. So you're going to have a milder infection if you are masked, or if the sick person around you is masked. You're going to have if you even get infected at all, you will get a less severe infection and you will survive it. It's when both are not masked that we have these big spreader events like we've been seeing lately, where lots of people get sick and they're very sick for a long time. The reason this is important, here's the key thing. Most infections we see are caused by transmission from somebody who doesn't know they're sick. See, that's the thing you got to realize. When you go out in public or you're dining, you make the mistake of going out to a restaurant and you got people sitting around you eating with no masks. You don't know which one of those is sick and doesn't know it. And so they can be coughing or just talking loudly, laughing, having a great time, shouting. You don't know who is going to infect you. You see, whereas if that person has a mask on, you can be sure that you're safe. Or if you're wearing a mask, you can be almost as sure that you're going to be safe. And if both of you are wearing a mask, there's no problem. So the evidence is absolutely clear that masking protects you. It protects those around you, and it also protects you. Also, if you have a mask on, but it's not covering your nose, you are protecting those around you. But you're not protected because you breathe in through your nose and you infect others through your mouth, you see. So just having it on your mouth, you're doing a nice thing for those around you, but you're not protected. So to me, that is a very dumb position to be wearing a mask but not covering your nose. You're leaving yourself as a setup.
Dr. Robert Haley, thank you very much for your comments and for your expertise and your voice in North Texas during this pandemic. When we come back, we're going to talk about the why of needing to wear the mask because COVID attacks the lungs. Pulmonologist Dr. John Burk tells us how and why next on the human side of healthcare.
The DFW Hospital Council, along with our over 90 member hospitals in North Texas, are proud to bring you the human side of healthcare with Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome to the human side of healthcare. We're delighted you're with us. And we want to do a little deeper dive as we discuss COVID-19. We've talked a lot about wearing masks, physical distancing, washing our hands, reminding people to get their flu shots. But we want to talk to a real expert today, and we're delighted we've got Dr. John Burk, who's a pulmonologist from Texas Health Harris Methodist Hospital, which, as you know, is located in Fort Worth. And we're going to talk a little bit about oxygen levels and COVID-19 and the impact on our bodies. Dr. Burk, can you explain to our listeners about oxygen saturation and how it affects each of us?
Perhaps a way to enter that discussion is to say, gee, what happens when we hold our breath? Our oxygen levels begin to fall, carbon dioxide levels go up, and we have to breathe. Our body likes oxygen. Our heart, our brain, our body as a whole doesn't do well if we do not have adequate oxygen delivery to the tissues of the body. That can be impaired for a number of reasons, that delivery of oxygen. But the one that we're going to face with COVID is the lung is unable to transport oxygen adequately across the membrane in the alveolus of the lung, those small air spaces of the lung, into the blood. We can help it out by giving more oxygen so that we increase the amount of oxygen that's inspired, but there comes a point that you can't even get it high enough to keep normal levels and thus preserve heart and brain function. In Fort Worth, our normal oxygen level at the courthouse is in the range of, if we're talking oxygen saturation, around 95, 96%. Take a few deep breaths, breathe hard, it may jump up to 98% oxygen saturation. As it begins to drop, there's some impairment of ventilation, being able to move air and get oxygen to the alveolus, to those air sacs, and into the bloodstream. Perhaps one thing that we could point out is there are two ways of measuring oxygen in the blood. The first that we usually think of in medicine at the hospital is with an arterial blood gas, where we draw a sample of blood from an artery that has just left the lung and the left side of the heart and circulated out into the body, and we measure the partial pressure of oxygen in the blood. And that scale is different than oxygen saturation. Oxygen saturation is what we measure with the finger pulse oximeter.
So let me ask you this. We've heard a lot about different people that have had COVID-19, even the president, and we hear 94% oxygen saturation frequently. Why is that such a magic number?
It's the number that has been recommended nationally to say, pay attention as it drops below this. Oxygen saturation is measuring the amount of oxygen that is being carried by hemoglobin in the bloodstream. So of the hemoglobin there, how much of it is carrying oxygen? And it's determined by an oximeter, a little device that now fits on the finger. Experimentally, they even have them that can be implanted. But now it's convenient, it's available in many drugstores and DME companies and on the internet, and they are reasonably dependable. But they have an error of plus minus 2%. So 94 could mean 92 or 96. So if you're going to be cautious, you choose a number that includes that lower possibility of 92, so that if it dropped below that, you're beginning to have a problem with oxygen delivery to the tissue, and therefore stressing the heart and the brain. In chronic obstructive pulmonary disease, COPD, the number is 90% or 88%. So that in COVID, they're choosing a number that is at the lower limits of normal. Part of the reason is that in COVID infection, pulmonary infection, we see Oxygen drops very rapidly in the course of a matter of a few hours. The oxygen level can just drop precipitously, so that as you cross into oxygen saturations of the 80, people are in distress. So it provides a safety net, a cushion, by choosing 94% as a level to begin to pay attention to.
Well, when it does drop, as you mentioned with COVID-19, when do you intervene and say, we need to provide additional assistance? And then how do you determine what assistance you give the patient?
Well, remember, it's a bigger picture than just a number. Part of it could be other underlying conditions that the patient has. Do they have COPD, for example? Do they have other risk factors for getting worse? Do they have fever? So you look at the whole of the patient and saying what comes next. But as it drops below 94%, may need to well be seeking medical attention. There is evidence that perhaps early treatment with the use of steroids, for example, can shorten the course of disease and perhaps avoid its worsening. The studies to date mostly have been done in hospital patients that have been sick enough to be admitted. There are ongoing studies looking at patients who test positive for COVID but never get sick enough to come to the hospital. Is there anything that one could do, or perhaps if we have the knowledge, should do, to prevent worsening of infection in those patients? That information is still coming, in my opinion.
You know, when we think in terms of ventilators, when COVID first hit back in February and March, especially as we looked at New York, it looked like quite a few patients were put on vents. What about now? It seems that we have vents, but we try not to use them unless absolutely necessary.
Good question. It would, of course, never be planned to be used in the home or outpatient setting, so it's always in the hospital. And it is a patient who is been admitted to the hospital with COVID with worsening symptoms and has failed to respond to treatment, which I'll review in a second, and is then moved to the ICU because their lung function, their ability to deliver oxygen has worsened, and the expectation is it's going to get worse, and they would no longer be able to support themselves with all the things we do short of intubation, meaning put a tube in the trachea through the mouth and putting a person on a ventilator. Of course, you sedate a patient to be able to do that and keep them comfortable through that, and patients will not remember any of that experience. Before going to the ICU, a patient is monitored closely, and one of the first things we do is prone positioning. It turns out that having people spend time in the prone position with their belly on the mattress helps improve ventilation to the lung and therefore oxygen delivery to the lung. We can add oxygen at the nose or the nose and mouth using high flow warmed oxygen and turn the concentration of oxygen up considerably to support a person and keep their oxygen levels in a normal range. PAP therapy has been used. They used it in Italy. That's positive airway pressure. And it can be delivered by a mask. With each of those steps, there is the potential for increasing aerosolization of particles from the patient that are infectious. And though personal protective equipment is used in negative pressure rooms with external ventilation are used, there's still the potential for infecting others that would be nearby, in this case, medical personnel. One of the things that's interesting is, and this, I don't have the information in front of me, but I have been told that medical personnel, looking broadly across the country, have had a surprisingly low rate of infection from COVID, even though they are right next to the patient and caring for them. And it's because they have used personal protective equipment, not only a mask, but a face shield, a gown, and gloves, and paid very close attention to technique in using personal protective equipment.
So let me ask you this. I've talked a little bit about the COVID-19, the oxygen saturation. You've done a great job of explaining this to our listeners. What else would you say is pertinent for this COVID-19 discussion that our listeners should know about?
Well, I think there are a couple of points that I'd take advantage of this opportunity to mention. One is that the recommendations of CDC to use social distancing, a mask, and hand washing does make a difference. There are now many reports and studies that say it makes a difference in the likelihood of being infected and transmitting that infection to others. So my best advice is listen to the experts and follow their recommendation. Having said that, I'll also share the last slide of a recent webcast from Columbia Presbyterian in New York, that the last slide reminded us that there are no COVID experts. It's only been present in this country for 10 months. We've learned a lot. There are a lot of smart people, physicians, doctors, who have understanding that they apply to this infection, but we're still learning. And just as we heard early on, is that things will change. We can expect further change to occur. The second point was a discussion of how long COVID virus lingers on surfaces. And it would be easy to somewhat get excited about it because on some surfaces it lasted for not just hours, but even days. The fine print of that study points out that it was in a dark room because ultraviolet light will kill the virus. Sunshine is good. It kills the viron. They also showed that at lower temperatures, the virus survived longer in the dark. So sunshine is a good thing in containing and killing the COVID virus.
This is Dr. John Burk. He's a pulmonologist with Texas Pulmonology and Critical Care Consultants in Fort Worth. More on what COVID does to our lungs next on the human side of healthcare.
We're continuing our conversation on how you can empower yourself to have the best health possible in today's ever-changing healthcare environments. This is the human side of healthcare with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
Welcome back to the human side of healthcare. We're continuing our conversation with pulmonologist Dr. John Burk from Texas Pulmonology and Critical Care Consultants. He is in downtown Fort Worth. And Dr. Burk, I'd like to understand that progression of what happens between the time somebody gets infected and the time that you start knowing that you need to supplement oxygen. So like we saw with the president, here's a diagnosis, and then here is pulmonary treatment that next day. What goes on in the lungs during that decline?
Thomas, you raise a good point of discussion, and we'll take a minute to consider that. Because, yes, the viron infects the lining of the airway, and the body responds. And for most healthy folks, that response contains the viral infection, and given a little time, eradicates the infection in most patients. In some patients, that viron produces a very intense pneumonia or pneumonitis, an inflammation of the lung. As that happens, oxygen levels fall and you provide more support. But for some reason that I know I certainly have not yet heard explained well, that inflammation that gets turned on in the lung begins to amplify on itself. And it's not the virus causing anymore, it's the inflammation that's turned on. It's an ongoing, and I'm going to use the word burn, if you will, as a sign of inflammation, but it's an ongoing inflammatory process that feeds on itself and progresses. Now you have all of the lung involved so severely that normal oxygen transport has been left. You can't adequately support the individual with all the extra oxygen in the world, and they have progressed and go to the ICU where even further support can be provided. During that time, yes, remdesivir has been provided as a treatment that seems to shorten the course of illness, perhaps avoid some of the complication. Convalescent plasma from patients who have previously been infected and have antibodies against the COVID virus has been used, both of which seem to make some difference in the intensity of infection. It also appears that the earlier these treatments are used, the more beneficial they may be, though that's not how we started. We started using these with the sickest patient, those that were the most ill. And when it did seem to help, well, you move it to a little earlier stage and a little earlier stage. And in the case of convalescent plasma, we learned from the study at the Mayo Clinic that in over 70,000 patients that received it, there was very, very minimal side effect or adverse effect, making it a safe treatment to consider. The scientists have worked hard in the laboratory to take those antibodies and reproduce them. So you don't have to have antibodies that come from someone who's been infected, but they can be made in the laboratory. And my understanding is that's what is happening now, that we are seeing antibodies against the COVID virion become available to be given in an early stage of disease. Thinking ahead, perhaps it's going to be, gosh, you've had intense exposure. There was an event that occurred, you cared for someone and they showed up with infection the next day. You've had a heavy exposure in a closed space, darkened room. Well, maybe that's an appropriate person to be preventive and give medication ahead, much as we've learned to do with other infections. But that's in the future. And whether it's going to be synthetic antibodies that become most important or the vaccines that become most important, we don't know yet. That's in the future. There was a well-documented case report in Utah of a patient who's now been reinfected, and it was very clear it was 2 COVID virus infections, but not precisely the same virion. We know that this virus has already had 2 mutations occur, and personally, I'll say I expect more to occur as we go along. Will a vaccine that is protective against one virion be protective against the next variation that occurs? I think the answer has to be right now. We don't know. We're learning, but we don't know.
That is all very interesting. Wow.
I've gotten very used to saying we don't know and I don't know.
Yeah.
Because there's so much we don't understand yet.
That's incredible. You think about all this effort toward the vaccine, and all of a sudden the virus turned right and went down a whole nother trail, and you're chasing another direction all over again.
It's like influenza, that we have a new vaccine every year because the influenza virus has multiple mutations it can make. There are a panel of experts that collect samples from around the world that say this is what's likely to occur as the predominant strain this season, and that's what the vaccine's against. But it's not always right. Sometimes it's only partially right.
With COVID-19, we've heard cases where young people, middle-aged people, older people get it. The disease progresses, it spirals like you talked about, and they die. We've heard cases where young people, middle-aged people, and older people get it, and they seem to bounce back rather quickly. What's the difference?
I wish we knew. We would use that as a form of treatment quickly. I know I have not read anything that provides an understanding of that difference, except the comorbidities that are associated with worsening disease, one of which is age. A primary one is obesity. One of the things that we don't yet fully know and have been explored is, does it make any difference what the inoculum is? Is it a single virion that can produce infection, or is it a huge inoculum that really produces a serious infection? And that will take a lot more study and a lot more time to understand the effect of the size of the inoculum. Lots to learn yet.
So the point seems to me, the big takeaway for folks listening to this show that are just driving around Dallas on Sunday afternoon, if you feel symptoms, you need to get a test because you need to get the treatment as soon as possible. Would that be summarized properly?
That would be fair to say, but part of what that treatment is monitoring temperature, oxygen saturation, and you also get heart rate as a free bonus when you do oximetry. So you monitor that and pay attention to symptoms, and then those measured parameters of temperature and oxygen saturation to say, gosh, if these things are worsening, temperature going up, oxygen saturation going down, I probably need to be seeking more medical attention.
Thank you, Dr. Burk. We really appreciate the information you've given us. Thomas, I don't know about you, but let me just tell you, after listening to Dr. Haley and Dr. Burk, that's some sobering information. You know what? It inspires me to keep wearing my mask. What about you?
Well, just like you, I've never let up, Steve. Yes and yes. And listen, if you don't mind, I'd like to just throw in, because I know people come in and out of the show here. What we've just been talking about is somebody who has almost a dozen years with the CDC and we have a pulmonologist who just explained what COVID does in our lungs. If you missed either of those in their entirety, they are on our podcast. It's called The Human Side of Healthcare. It's on all the major podcast players, and we would just really encourage you to listen to that because it is information from some of the best experts in the field.
And you know, Thomas, I know people get tired, and I understand people are fatigued. You know, the hospitals want the economy open. The hospitals want everyone to get back to the closest way to normal as possible. But we're going to have to do it where we coexist with this virus until we get a vaccine. And by doing so, we've just got to wear that mask. We've got to physical distance. We've got to do it in a cooperative spirit. And I know that people get tired of hearing it, but we just can't let our guard down.
There was something else that you mentioned on several shows back when you were taking a look at the Southern Hemisphere at the beginning of our summer and, of course, the beginning of their winter, where they weren't getting the flu as much, and they were tapping down. And what you were indicating is the combination of what they saw us going through. They started wearing masks. They did have some pretty good restrictions in several places, but the Southern Hemisphere kind of got through their winter without a big outbreak.
They also got flu shots. They had a high compliance of people getting flu shots, and the flu vaccine that they got was very effective. Hopefully that's going to be the case here. So, Thomas, I know you've gotten your flu shot. I've gotten mine. But to our listeners out there, if you haven't gotten your flu shot, please do so.
Next week, we're going to talk about faith in action, boots on the ground on the human side of healthcare, and how that's been translating into the world of COVID-19. That's next week here at 1 and 7 on 1080 KRLD
and radio.com.